Hello all, my name is Kevin Deane. I'm a rheumatologist here at the Division of Rheumatology. My talk today is going to be an update of a talk I gave back in 2016. I've changed the title to now be Updates in the Prevention of Rheumatoid Arthritis. I have some disclosures around grant funding and consulting from industry. And then I think these slides are available for everybody, but here's a couple of evidence-based reviews that talk in much more detail about what I'm going to talk about today. So the disease that I'm focusing on here is rheumatoid arthritis. It's an immune disease that primarily affects the joints, certainly can affect other things, including the lungs, and it's one of the most disabling forms of arthritis. It's also highly prevalent in the population as far as autoimmune disease goes. About 1% of the population, and I updated this slide from 2016. I just have to laugh a little bit about the number of name changes our Bronco Stadium has gone through. Hopefully I got this right, it's now Empower Field, but 1% of the population. So if you were at a football game, that would be a little over a section full of people with rheumatoid arthritis. So pretty dramatic number of people with this autoimmune disease. So it's associated with a lot of things for an individual with disease: pain, fatigue, loss of function. There's also extra articular manifestations. Heart disease is actually one of the biggest killers prematurely in rheumatoid arthritis. So folks with rheumatoid arthritis get heart disease about 10 years earlier than they would if they didn't have rheumatoid arthritis. There's medication toxicity, very expensive. There's actually overall reduced lifespans. So it's a very impactful disease. The current paradigm of how we identify and treat rheumatoid arthritis is to treat the disease once it's clinically apparent, which is once somebody has started to have joint symptoms, pain, stiffness, or swelling, made it through their primary care, gotten an evaluation, figured out that they might have some kind of inflammatory arthritis, finally referred to rheumatology, and finally made a diagnosis, which that process has been looked at in the United States, takes on average 2 years from the onset of symptoms to the final diagnosis and treatment for rheumatoid arthritis. That's too long. The disease actually damages within the first few months of disease. So an overall premise that I'm going to build on here is, what if we could find RA and stop it before people actually started having joint damage? I'll talk a bit about the rationale for that statement and that idea, and then talk about what we're doing to try and do that. So we now know that rheumatoid arthritis has a staged or phased set of things that happen in terms of development. Here's a picture at which point someone would show up in clinic and get diagnosed. But now we know from a variety of studies that I won't go through in huge detail in a short time today, that there's a preclinical or pre-RA period that happens long before this. And on average, 3 to 5 years, but it can be up to 15 to 17 years in some studies, where genes, environmental exposures, combine to first trigger a period of asymptomatic autoimmunity and inflammation that's detectable with blood tests or other tests. Now we're realizing that these tests can be abnormal in mucosal surfaces as well. A person can progress, start developing early symptoms of rheumatoid arthritis, but nothing you could define yet in a clinical exam, i.e. you wouldn't see a swollen joint. Then it finally comes to the point where there are signs and symptoms, and you could say, yes, this person has inflammatory arthritis, and then ultimately classify them as having RA and start treatment. So I'm going to focus the rest of the talk on this preclinical, also called pre-RA period, and what's happening in that period, and how we're planning to intervene to try and prevent the onset of this clinically apparent disease. So a first little digression here is to help understand how we know about rheumatoid arthritis and how we measure it's going to develop in individuals. There's autoantibodies. I think people are familiar with these. There's 2 big systems that we think about in terms of rheumatoid arthritis. There's rheumatoid factor. It's been identified for decades. There's a newer system that we may be less familiar with. It's called ACPA, or antibodies to citrullinated protein or peptide antigens, depending who you talk to, but ACPA. The clinical term that we use for the clinical assay that's available in all the labs is called a CCP. So ACPA is sort of an umbrella term. CCP is the specific clinical term. What this measures is antibodies to post-translationally modified arginines into citrulline. So we all make citrulline in our body all the time. It comes along with inflammation. It comes along with normal progression. One of the things, the reasons we often don't have webbed fingers is because citrullination occurs within cells, and it causes those cells to be orderly apoptosed and reabsorbed. So it's part of our normal physiology. What's unusual is autoimmunity to citrullinated proteins. That's highly specific for rheumatoid arthritis. Just to get into the weeds a little bit, but it does help me explain some things a little bit later. The commercial assays for antibodies to citrullinated protein are called CCP. They actually measure antibodies to a whole variety of citrullinated proteins, citrullinated vimentin, fibrinogen, other things, but it just gives you a one readout, so just a level. We can actually break that apart into research assays where we can actually look at antibodies to specific citrullinated proteins and actually count them up and say, oh, an individual has reactivity to 8 citrullinated proteins or 10. That's going to help understand how we've understood rheumatoid arthritis, but the commercial assay doesn't tell you that. It just gives you kind of one readout. That's a little bit about the antibodies. Now here's my most complicated slide to tell you how we think rheumatoid arthritis develops. I'll walk you through this one to make sure we understand it. So these are images from a group of individuals who have blood collected on average 10 years before they get rheumatoid arthritis, and then after they got diagnosis. And on the left-hand side are people who develop rheumatoid arthritis. On the right-hand side are serial match controls. We got these folks from the Department of Defense Serum Repository, which is a great resource. If anyone wants to talk about how you can look at natural history of disease, I can inform you about that offline. Basically, if an individual's in the military, develops rheumatoid arthritis, you can go find them and then go back in time and find blood that's been collected through this Department of Defense serum collection system and look at blood before they get disease. So that's a background to this slide. Individuals on the left-hand panel will focus there, developed rheumatoid arthritis at this time point. And then these are sort of intervals before they develop rheumatoid arthritis. This is back to that point I made earlier. You can measure individual antibodies to a variety of citrullinated antigens. If you just squint at this slide, you can see that the red color increases over time. That means individuals are developing more and more autoantibodies to a variety of citrullinated proteins. They start off with very few, they get more and more and more and progress to the point where they get RA. They have a lot of autoantibodies, and then this is that threshold they cross and develop clinically apparent disease. So following that, also there's an elevation of inflammation that goes along with that. You won't be able to read this, but there's a whole list of cytokines down below. And if you can kind of squint, the red colors increase over time to the point at which a rheumatoid arthritis clinically develops, and you can see there's a basically storm of inflammation through a variety of cytokines. Fortunately, this doesn't happen in folks who do not get rheumatoid arthritis. So if you just look at the red colors on the right-hand panels here, there's not that increase of redness. So this is really unique and specific for rheumatoid arthritis. There's, of course, other immune systems that are going abnormal in this period. There's rheumatoid factors also developing along with these antibodies to citrullinated proteins. There's a whole host of new antibody systems that we're learning about as we go. I won't go into that in great detail. There's a growing number of cellular studies in this period as well. And kind of at a layperson level, one can think of this as a little bit of inflammation at a candle level, probably 5 to 10 years before you get rheumatoid arthritis, a campfire level a couple of years before, and finally full-blown fire, which is the clinical disease of rheumatoid arthritis. So you can start trimming this down and looking at this in a little bit clearer way. And if you just count the number of ACPAs, we're referring back a couple slides back, where an individual can have antibodies to one citrullinated protein or another, if you just count those up, what happens is people start off with a low number of antibodies to citrullinated proteins that increases over time to the point at which they get rheumatoid arthritis. If you count the number of cytokines that are elevated, that increases over time. And importantly, understanding that model of how RA has developed has led to ways to use antibodies to predict who is going to get rheumatoid arthritis in the future. And it can be boiled down even more simply with the CCP assay. And I won't go into the details here, but one of the more common assays is a CCP3, which is just a commercial version. You can use one single assay that gives you a single readout. Levels can go from very low, or what would be considered normal, increase over time, cross a threshold at which point they're considered positive, and then increase in a person finally develops rheumatoid arthritis. This makes prediction quite simple because one can now use one commercial assay and say, what is your level? And then get an estimate of your overall risk for rheumatoid arthritis, as well as what time period in the near future you may develop rheumatoid arthritis. So this figure kind of tells you that. You can see levels can go up And the level here is on average 2 to 4 years before somebody gets rheumatoid arthritis. And this is a level, which I won't show you this picture, is unheard of in somebody who doesn't go on to get rheumatoid arthritis. So both specific for disease and helpful in terms of timing of prediction of future disease. In fact, you can boil this down to a simple model where a CCP3 of greater than 40 units gives an overall risk of 50% for developing rheumatoid arthritis within the next 3 years. So what is helpful here is these ACPA tests, in particular, that commercial assay CCP, is very specific for rheumatoid arthritis. Indeed, if you have synovitis, it looks like rheumatoid arthritis and this test is positive, it's really over 90% specific. If you don't have synovitis, there's probably a 90% positive predictive value in some case control studies, maybe as low as 30% in others, but really a high positive predictive value is that you will develop rheumatoid arthritis in the future. But certainly, as I've mentioned before, likelihood and timing need to be addressed in prediction. That's where that model of the test being positive and positive at a certain level gets you both likelihood and timing of rheumatoid arthritis. Now, importantly, this has underpinned prevention studies in rheumatoid arthritis, where one can go out, find individuals who have elevations of these biomarkers, and then intervene to try and prevent or delay them from going on to get rheumatoid arthritis. And there's a bit of a landscape of RA prevention that's evolved since I gave this talk in 2016. There was one known study, which is called the Dutch dexamethasone study, where individuals that had either high levels of rheumatoid factor or ACPA and had some aches and pains, but no inflammatory arthritis, were given 2 doses of dexamethasone at a pretty whopping dose. It did not halt progression to inflammatory arthritis. It decreased the autoantibodies a little bit, but this was overall considered a negative study. That was followed up by a study called Prairie, which was published in 2019, where people who were positive for ACPA and a rheumatoid factor received 1 dose of the B-cell depleting agent rituximab. It actually did not decrease in overall progression of inflammatory arthritis, but it did slow the onset of disease. So thought to be a successful trial, although it wasn't a complete prevention. A couple other studies have had readouts recently, a study called STAP-RA, where people were given atorvastatin to try and intervene in folks that were ACPA positive to try and prevent future disease. The atorvastatin did not work at all. The rationale behind that was because we know that atorvastatin actually, in addition to cholesterol modulating factors, has some immune factors. That was the rationale for that drug, but it did not work. And so it's taken it out of the running for trying to prevent future rheumatoid arthritis. And then this is just got breaking news. It's only been in abstract form in the last couple of months here. A study in Germany where an individual that might have ACPA positivity or the CCP assay, plus evidence of inflammation in a joint on MRI, but that's not something you could see on physical exam, are given a drug called abatacept, which is a T-cell co-stimulation blocker, versus a placebo. And an early readout here is that it's actually decreasing the progression of rheumatoid arthritis. Very exciting findings, but that needs to be fleshed out. But with that as background, a few years back, we developed our own prevention study that we call STOP-RA. And the big name is Strategy to Prevent the Onset of Clinically Apparent Rheumatoid Arthritis. This was funded by the NIH and NIAID through a special branch, the Autoimmunity Centers of Excellence. We're the principal site here. We developed the study, but we're operating on multiple sites across the country. I think my colleagues, Chris Strebick and Mike Kohlers and Marie Fazer, who's been our primary study coordinator here, who've really helped launch this study. I think all of our rheumatologists in the state, a lot of rheumatologists across the country, in a cast of thousands, which is sort of a joke, but I'll tell you, it's not actually a joke when you see what we've had to do with this study. So what we did with this study, develop an inclusion criteria, harkening back to a couple slides back, where we used this ACPA test, the CCP3 test that was 2 times normal, without a history of inflammatory arthritis, with a projected rate of development of rheumatoid arthritis of 50% by 3 years. We have subsequently learned that that might be a little bit of an overestimate, but I think that still needs to be evaluated further. That has some importance with the slide I'm going to show you in the next couple of slides. The intervention that we selected here was a randomized, blinded, placebo-controlled study using the drug hydroxychloroquine, which is a bit of a mystery on how it works. It was originally used for malaria treatment, probably because it elevates the pH inside of cells, causing it to be an unhospitable environment for malaria. that probably also alters immune function of cells and dampens it a bit, makes cells less autoreactive, less inflammatory. And we think that's the mechanism why it works in a variety of diseases, include lupus and rheumatoid arthritis, which is used widely for. The intervention was giving the drug for 1 year, stopping, following 2 years of follow-up after that to see if the drug worked. Was there a durable response? It was kind of a shoot the moon hypothesis. A time-limited drug intervention in this preclinical RA period would reset immunity, lead to lasting improvement. The endpoints were development of classifiable rheumatoid arthritis, which harken back to those pictures I showed you earlier, basically a patient with swollen joints. Safety was also a primary outcome. Study design, just real briefly, an individual would come into the study, get 1 year study drug with a few visits, and then 2 years off a study drug into follow-up. So we've actually completed randomization of the study, and we're now in the follow-up phase. A couple people are still on study drug. We've randomized 140 subjects, which we revised that. We were aiming for 200 to start with, and some interim analyses realized we could do with a little less people and find a significant result. The study's ongoing, so you won't get a punchline here today. Hopefully we will have this read out very soon, and I will be able to provide us and the world, frankly, with the results from the study. I will just spend a couple of minutes here. If you're going to develop an agent that you can put into an at-risk period of disease, there's a lot of considerations that have to go into that. Is it going to work? Is it going to be safe? Is it going to be tolerated? Is it going to be cost effective? Are people going to be willing to take it? So we considered all these things, had some focus groups a few years back when we were launching the study. And we arrived at this drug called hydroxychloroquine, or Plaquenil, which no one had ever heard of before COVID came along. And then suddenly even the president's talking about this on news conferences. So a lot of people are still aware of it. It is something we use widely in rheumatoid arthritis already if you have established disease in lupus, but this was our final choice. Another aspect that came into this was it was a drug that anyone could prescribe. It's pretty safe. It doesn't really require specialist management of the agent. So if it is going to work, it's be a great drug. So this is why we're trying it. As one of my colleagues, Chris Trubik, has said, this is a drug that either has to succeed or fail, because if we don't look at this drug that's commonly used in RA, people would always wonder, does it work? Because it's so safe, and if it's effective, that will be a great option. So this is why we looked at it. And I will just say, here's the joke slide. This is a Lakeside Park here in Denver. Asked me sometime offline about using a drug, hydroxychloroquine, in the study, that when you started it, no one had ever heard of the drug, and suddenly everybody wants to take the drug to prevent COVID for a few months there. And indeed, the NIH came to us when it was looking early days, like there was some question of whether COVID looked like it was going to work, about stopping our study and diverting all of the hydroxychloroquine we had for our study into clinical trials against COVID. It's hard to argue against that if it's thought to be life-saving, but fortunately that died down. Our study kept going basically uninterrupted throughout the COVID crisis. So our enrollment goals for the study were actually higher, and as I said, we lowered that estimate. We completed enrollment randomization for 144 subjects back in November. It was certainly a challenge. So if you think a disease, like harken back to that picture of the Broncos Stadium, 1% of people are affected by rheumatoid arthritis. So that means maybe 1% people are walking around out there who are at risk for future rheumatoid arthritis. It's probably even lower than that, right? Because not everybody's actually going to get rheumatoid arthritis. So the challenge is of how do you go to a group of people, find who is CCP positive and going to get rheumatoid arthritis in the future. And then the next part of that is how to get them to participate in the study. And that's been a huge challenge of the project for Stop RA. And if I can't thank people enough, we thank the 17 study sites across the country that have participated, as well as a huge effort of the state of Colorado. We've had a lot of things come together to help us with enrollment for the study. We've worked closely with the 9 Health Fair, the Arthritis Foundation, the campus here, a lot of providers on campus who found these folks in their clinics and referred them to us, a lot of rheumatologists across the state. So a variety of ways. Testing first-degree relatives, or FDRs, of people with rheumatoid arthritis gets you a higher risk group for future rheumatoid arthritis. Sometimes people show up in rheumatology clinics or primary care clinics with aches and pains, and they test positive for CCP but don't have inflammation in their joints yet. And then we can do some population-based approaches. I've already mentioned we used the 9 health fairs here in Colorado extensively. Other groups that have participated with us, including groups in Oklahoma, added on a CCP test and a short consent to about 5,000 people who donated blood in Oklahoma, tested them all for CCP and recruited a large number of folks out of that group to participate in our study. We've looked at some other stored biobanks at sites including Mayo Clinic and Brigham and Women's Hospital and found CCP positive that way. So the scope of this, and I'll just kind of boil this down in the interest of time, is we've tested in the past few years 30,000 individuals for CCP at 17 sites across the country at a rate of about 1.5% positive, or about 450 individuals were CCP positive at I left this out, at a level of CCP at 2 times the normal cutoff, so a little bit higher than just an average positive test. And we were able to, out of that 450 people, randomize the 144, or about 30%. Now, a bunch of those folks joined the study. Fortunately, some were willing to get tested and even been then presented with the drug hydroxychloroquine, didn't really want to take a medicine because they felt well, so dropped out for that ways. And a portion of those folks dropped out of the study because they actually wound up having undiagnosed rheumatoid arthritis. And so that's some additional challenges when you get into the prevention game and start screening for people. One, finding people to test. The test is fortunately specific for RA, so one avoids mostly finding other conditions that you got to worry about. This is a consideration, especially with the RA test rheumatoid factor, which can be elevated in Hep C, chronic infections, or malignancy. So if you find somebody who's rheumatoid factor positive in absence of CCP, you got to worry about all these other conditions you may have inadvertently discovered. But really, CCP avoids most of that. But one of the biggest challenges we've had in the study is previously undiagnosed rheumatoid arthritis. And once you find somebody in the screening pathway, to identify that and identify a pathway to care for those individuals. That's a lot of ethics around that. If you find somebody in your screening that has the disease of interest and they're not good for your prevention, how do you help them get to the right place? So this is the cliffhanger here. The interim analysis of the study is pending. But we have some early data that 30% of subjects have developed rheumatoid arthritis as part of the study. That's a bittersweet finding. I would just say anybody who's CCP positive really doesn't really think they're going to get rheumatoid arthritis, or certainly doesn't want to get it. But it is important in this prevention study to actually have people get your outcome of interest to see if your intervention can actually lower an individual's risk for going forward. So I will keep the campus and the world posted on this as we learn more in the next few months, hopefully, because we've fully randomized and we'll be able to have at least a good interim readout very soon. So in thinking about this trial, thinking about some of the trials that came before it or have been published since we started this, it's really mostly critical to learn everything we can about all aspects of prevention as we move ahead, because admittedly, when we started this, we had some grasp of the concepts that we were going to have to deal with, but as we've moved through this, the whole process, there's just huge challenges in trying to identify and screen and prevent a disease. And this slide is very busy, but it has a lot of the elements that have to come together. I'd say the most important thing is finding subjects or individuals who are at risk for disease and getting them to participate. That's critically important. Certainly finding funding from a variety of sources, getting industry to participate. You can envision industry in rheumatoid arthritis as a model that's built on, once you get disease, it's a forever disease. We got to keep giving you drugs forever. But if a prevention approach actually abrogated that or changed that, industry may have a very different look at a disease. And so you really want to have them interested in wanting to push for prevention. Measuring lots of other things, including outcomes, is very important. Getting healthcare systems to participate in this. Ultimately, if we find a drug that works to prevent rheumatoid arthritis, how to launch that into actual clinical care. A lot of things to think about. I will say probably the most important thing, thinking about some of the drugs that we thought were going to work really well to prevent RA that was published already, rituximab, steroids, and then we'll have to see if abatacept or this T-cell co-stimulation works. But thinking about the basic science of this disease development, do we really know what we're doing with our interventions? Are we making the right choices? And really, this slide kind of highlights the statement here. Understanding the RA pathogenesis is rapidly advancing, and it'll actually fundamentally probably change our next prevention trials. The good news is I think we have now set in the field that you can find people who are at risk for future rheumatoid arthritis and who will get rheumatoid arthritis. I think the field has also thought it's probably worthwhile trying to intervene to prevent this disease. those are two huge hurdles. Now finding the right approach to prevention is the next big step. And just a shout out to some members of my division. I think you're going to hear some other talks through the same lecture system going forward about these things, including a mucosal hypothesis, which I won't go into in huge detail today, but to touch on this, Christy Kuhn, Kristen Demerol, both in the Division of Rheumatology, Megan Criswell, who's a grad student who's been working on this extensively, have really help us understand that the early phases of rheumatoid arthritis may not be in the joints at all, but other sites. And that's, I think, it'll be groundbreaking for how we approach prevention in the future. So I have a figure to kind of highlight this here. Ultimately, when we want to think about rheumatoid arthritis, how it develops and where we might be able to prevent, we want to intervene in the future with approaches that are rooted in stage-specific biology. So if we have a person who on the right-hand side has joint disease and involvement in rheumatoid arthritis, where we have lots of experience in developing drugs and intervening with drugs. Now we've taken that experience and moved all those drugs into an earlier phase of rheumatoid arthritis. Hydroxychloroquine, even atorvastatin, and all the other drugs I've talked about are all well studied in the articular disease of rheumatoid arthritis. We're moving them, and that makes a lot of sense. Approval, like the FDA wouldn't approve a drug that's novel in prevention of RA unless it's already been tried in the existing disease, so that helps it. So this makes a lot of sense. But I think where we want to think about going forward in rheumatoid arthritis prevention is understanding this propagation or systemic immune phase without the arthritis and identify what are the novel targets in this period, precisely identify those for given individuals, maybe they're mucosal, and then really what I want to say is make the punishment fit the crime. So if I can profile autoimmunity as a crime of health, we want to be able to understand it and then target that appropriately, so we really balance efficacy of an agent versus risk and benefit, so we do the right thing to try and prevent future disease. Hopefully this will not only work for rheumatoid arthritis in the near future, so we're looking forward to readouts. Certainly Stop RA is a RA focused thing, but we have a lot of other autoimmune or rheumatic diseases that may be following similar models of development where there's a pre-disease period that we can intervene upon. Actually, trials are underway now in lupus that are similar and designed to stop RA. Some studies in gout. There's some studies in ankylosing spondylitis and related diseases, including psoriatic arthritis, to try and intervene early to prevent an end organ toxicity or damage from that. So that's very exciting. I think many of you already know about lots of extensive work in type 1 diabetes, so I won't go into that today. But this is kind of the big dream. If we can develop models to take somebody from a healthy standpoint, from whatever organ you're interested in, intervene with studies such as Stop RA, develop ways to prevent. I think that's where we'd like to go with rheumatoid arthritis and other diseases. Frankly, I'm tired as a rheumatologist to wait until sick people come into clinic. If we can go out and find them earlier and intervene earlier, I think that's going to be great. My last slide is to think of, there's too many people to put on this, so I thank some key people. My boss, Mike Holers, and Jill Norris, his wife, have developed a lot of these early studies and really set a foundational framework for the development of this. The original studies were under the umbrella of the Studies of the Etiologies of Rheumatoid Arthritis, or SARA. My colleague Christopher Strubeck and our state coordinator who's driven forward a lot of this, Marie Fazer, have been huge help. Kristen Demerol, Christy Kuhn, our now division head, Dwayne Pearson, have been hugely instrumental in driving a lot of these forward. We've had lots of funding from lots of agencies. Mostly, I'd like to thank the NIAID, who have supported our Stop RA trial, but we're getting a lot of other institutional funding and others to move this ahead. And with that, I will stop and leave this slide and address any questions. I think I'm still the last talk, right? I've gone a little over, but hopefully there's time for questions.
If there are any questions, you can please enter them in the chat.
I think I can see the chat, but I can see it better if I stop share. So I'm going to stop sharing if that's all right. Natalie, maybe if you can say, I don't see any questions in the chat.
I don't see any either.
I'm not missing anything.
Mm-mm.
Okay. All right, I guess if nothing's coming through, are we done?
Here's a
here's
question,
something.
Eric Poshla. Where do ISGs fit into your evaluations?
So what is an ISG? So interferon stimulated genes, they certainly don't fit into any clinical assessments or laboratory assessments we do now. That said, there is a growing understanding that there may be an interferon signal in the early pre-RA period. You've opened the door for a discussion here. We don't think interferon is a huge player in established rheumatoid arthritis, but biologically it looked like it might be from older studies, including systemic inflammation and actually articular inflammation, that interferon might play a role. Interferon blockade did not work well. Doesn't mean it's not important in established disease, but at least the drugs we had didn't work well. We think that actually they may play an incredibly important part in this very early phase. So this is part of that picture I showed where things we know work in established rheumatoid arthritis may actually be different than what we need to use in earlier disease. And so interferon stimulated disease are a new target for thinking about in terms of preclinical disease, because maybe at that earlier stage, these are much more critically important pathways. So the concept is there. We're trying to now understand exactly what pathways are there to be able to target them effectively.
Are there any other questions from anyone? Well, Dr. Deane, thank you. I apologize. Our moderator couldn't make it today, but we appreciate your speaking today.
Hey, thanks for the opportunity. And I think everybody has my email from campus if you have any questions that come up later. Thank you. Bye-bye.